Thank you very much. I appreciate it and excited to be here and to share this project with everyone. So today we're going to be talking about a program that I was involved in during my fellowship and into my early career here at UCSF. And it's about a simulation-based training program that we developed for pre-hospital providers in Botswana. And what I really, well, let me start off, sorry. I have no conflict of interest at all. I would just like to acknowledge that we did receive funding and support from Texas Children's and Baylor College of Medicine for this project and the Botswana Ministry of Health. And Dr. Megan Cox, who at the time was the head of the emergency department at the main referral hospital in Haberene, Botswana, Princess Marina Hospital. So I would like to thank all of them for their support. So the goals today, what I'd like to do is really just discuss the general principles of curriculum development. You may have had this in previous lectures, but I just wanted to walk you through and make sure maybe it's a refresher for some of you. Make sure you feel comfortable with the steps and how you develop a curriculum. And then how to basically relate the curriculum development to medical education and specifically to this simulation-based training program in Botswana. So, the objectives, I'd like to go into the details and general steps in curriculum development, and then list the different considerations. I'd like for you to be able to list the specific considerations specific to medical education and curriculum development. So as background, so I worked in Botswana. It was from 2014 to present date. I started working there when I was a pediatric emergency medicine and global health fellow at Texas Children's Hospital or Baylor College of Medicine. And at the time when I started working off in the emergency department at Princess Marina Hospital and spent some time talking to different people and meeting with the Ministry of Health, figuring out basically the lay of the land. But pre-hospital care really began, the Ministry of Health pre-hospital care began in June of 2012. And this was in response to the Botswana Ministry of Health concerns regarding potentially preventable morbidity and mortality. At the time, the Botswana Ministry of Health had 8 emergency medical services, now has more than 10. I believe they're up to 12 EMS centers throughout the country, which combined at the time had approximately 150 EMS providers of different levels serving a population of greater than 2 million. And the Ministry of Health had identified specific deficiencies in the basic resuscitation skills of the EMS providers, specifically with the pediatric patients. And to get an understanding of how this EMS program began is that there were no schools for EMS providers, no paramedics, no paramedic training in the country. When the Ministry of Health had decided that they wanted to start this EMS program, they basically pulled medical professionals of different levels, so nurses, medical technicians, who are working in different fields, and basically reassign them to EMS. And so imagine one day you're working, let's say as a surgical nurse, and then one day Ministry of Health tells you you're now a nurse that's going to be working as an EMS provider. So they had very, very little, most of the staff had very little training in pre-hospital care. So, back in 2012, at the time, President Khama of Botswana had appointed Major Bushe Laba, who is in the picture to the right in the blue button-down shirt, to head up the Botswana Ministry of Health program. And he became the first trained paramedic in the country after Botswana invested in him to go to Australia for paramedic training. At the time, there was no other local paramedic training. Since then, there are many programs, especially in neighboring South Africa, where Botswana is able to send people for paramedic training. But at the time, that was what was available. Boucher, or Major Labe, was incredibly dedicated and passionate about this position with the Ministry of Health, and was and still is deeply invested in making the program succeed. He unfortunately had a personal tragedy related to EMS when his younger daughter, who was an asthmatic, unfortunately had a severe asthma exacerbation. And at that time, this is pre-2012, there was no EMS services available in the country. And unfortunately, he couldn't get his daughter to the care she needed in time, and she passed away. So really, Boucher, at that point in time, really wanted to devote his time and his efforts to make sure that this situation would not perpetuate. So sad story, but Boucher is really just unbelievably committed to making the EMS program work. So before we jump into details of the EMS program in Botswana, I just wanted to talk about the different steps of curriculum development. As some of you are aware, there is a model for this. It's Kern's model for curriculum development. And it's really important when you are developing a curriculum to really take a systemic approach to ensure that all local needs are met, and that you are targeting the needs and the focus of the curriculum to the population, the specific learners that you're going to be teaching. So there are 6 different steps to this model, and we're going to walk through each of these for the Botswana EMS project, just as an example. But step 1 is really just the problem identification. And so what is the issue? Is there an issue? And I think as someone coming from outside of the Botswana medical system, it was important for me to take the time to meet with the different local providers, leaders in healthcare, to get an understanding of what the environment was like and what their needs were in Botswana. I think all too often it's easy, as coming from an outside system, or maybe even a more developed, especially a developed EMS system, it's easy to come in and identify many gaps yourself, and then come in with your own biases and think you have the solution for all their problems, and it turns out that your approach is not exactly what's needed. So it's really, I can't emphasize enough, and we'll talk about this a little bit later, the importance of spending that time in the beginning to identify the problem and to develop relationships. The next step is the needs assessment. And again, this is a needs assessment that's targeted for the specific learners that you're going to be teaching. You want to be able to develop the goals and objectives, the specific education strategies, have a plan for how you're going to implement this curriculum, and then have an opportunity for evaluation and feedback so that you can change the program if necessary, and make sure that you're hitting the target points that you want to. So the key points of the needs assessment, which is after you've identified the problem. And for me, it was a matter of spending multiple trips. At the time when I was a fellow, I would spend 3 to 4 months a year working in Botswana. And that first year, all I did is work in the emergency department, have meetings with different Ministry of Health providers, and get an understanding of, or get the lay of the land and understand what the different needs are. And it was really Boucher, during one of my meetings with Boucher Laba in the Ministry of Health, he had identified this specific need to develop a training program for the EMS providers in Botswana, mainly based on the fact that so few of the people that worked in the program had any background training in EMS. So we had identified this issue. We had some key stakeholders, and then we decided we were going to do a needs assessment. And so the key points of a needs assessment are that you're looking specifically at your group of learners, and you want to identify, what resources exist, who are the key stakeholders, and not just the availability of staff and ambulances, but really what equipment is available and really reliable for the EMS teams to be able to use. And again, as I said, can't stress enough the importance of developing relationships with the stakeholders. It's incredibly important to work with these stakeholders and identifying, local champions for the project. And I think you'll find that the more time you spend on this in the beginning, the more it will pay off in the long run. And as I mentioned before, this will also help you understanding the intricacies of working with this specific population. It also helps to reduce your imposing, your own biases on the project, and helps to ensure that the project goals align appropriately. So, you want to get understanding of what the prior knowledge and experience and training of the existing EMS staff or your learner groups are, and really analyze the data and the setting the different priorities of the group for future action. And so you really do this through a mix of surveys, focus groups, and in-depth interviews, and understanding and really taking a look at the data to get a better understanding of the demographic information and statistics of your particular project and population. So, the objective of our project, as I mentioned, or of this needs assessment, was to assess the educational needs of the pre-hospital providers in Botswana Ministry of Health EMS system. By number one, we are going to take a look at the demographic and data that's available to us. And we did this by reviewing response calls or EMS calls for the Botswana EMS system. Again, this is in 2014, so the program had been up and running for 2 years. And we wanted to analyze different trends in common response calls for pediatric and adult patients, and then wanted to identify potential skills required for the EMS response. What do we need to help them learn so that they can better serve their community? So the survey and focus groups of EMS providers helped really to identify any gaps in knowledge and skills, and also helped to identify opportunities for additional training. And this was critical as the Ministry of Health, as I mentioned, just started just a couple years before, and very few providers had any training. And then for the data analysis and demographic investigation, what we did is we took a convenience sample from a year's worth of EMS data. So we took from January to December 2014. We looked at the logbook of all EMS response calls in Gaborone, the capital of Botswana. And then we analyzed for the following variables that we looked specifically at the age of the patient, sex of the patient at the time of the call, chief complaint, secondary chief complaint, the priority level, which was basically the acuity level, where the patient was delivered to, and whether it was a call out, like a response to a scene, or was it a transfer call, like transfer from one hospital to the other. And then with this data, we did chi-square tests to analyze the categorical data. So here are the results of the most common EMS chief complaints. We broke it down into the most common response calls for pediatric patients, for adult patients. And then we looked at, identified the applicable skills skills training that would be needed for the type of patients that the EMS are most commonly caring for. So some of these skills, we did identify some skills that we felt would be helpful and really were a priority. But we also, again, we looked at the existing equipment that the EMS team had. And so we couldn't necessarily, or we decided not to train them on every single skill just because sometimes they didn't have equipment available. Examples of that would be if you had an adult that went into cardiac arrest. We did not do defibrillator training because at the time there was only one defibrillator with the Ministry of Health team for the whole country. So it just did not seem logical to start training on that, but certainly something that we could train in the future once we were able to procure more equipment. So when developing the goals and objectives, you really need to be thinking about what it is that you want the participants to walk away with. Goals should be very general, should relate to the curriculum itself, and should pertain to knowledge and understanding, whereas the objectives are more specific. They relate to the learner, him or herself. They should be measurable, and you should be able to demonstrate behaviors with these objectives. It's always important to have SMART objectives. This is the mnemonic that really brings structure and trackability to the goals and objectives. So your objectives should be specific, as I mentioned, measurable, action-oriented, realistic, and time-framed. And again, your goals and objectives should be linked. So we use this framework to develop learning objectives for the course. And this slide is just an example of one of the prioritized needs for this training. And this goal was neonatal resuscitation. So the plan was the focus was to enhance skills in newborn resuscitation for the Botswana program. And so for each scenario that we developed, we had different cognitive, technical, and behavioral objectives. And shown here on this slide are the different examples of each of these for the neonatal resuscitation scenario. So as you see, I won't read through all of these, but cognitive is basically knowledge-based information. Technical relates to the specific skills that you want them to learn. And behavioral relates to any changes in practice you're hoping they adapt as a result of participating in this training. So once you have your goals and objectives identified, the next step is really to identify or decide, how do you want to teach this material? And so, you should have a detailed planning of the instruction methods that will best achieve your goals and objectives. And, as we were looking into it, simulation really was one possibility for an instructional method that we could use. And there are different, we knew that there are multiple different simulation modalities available for us to use. So after discussion with Boucher and the Botswana EMS team, we had decided that simulation was really going to be the education modality of choice for this training, really because we knew there was evidence that simulation training does provide healthcare providers an effective way of developing clinical knowledge, procedural skills, teamwork, and communication, all of which are paramount in the pre-hospital setting. So we decided, simulation would be the main method of teaching, but we also knew that there was going to be importance of doing the hands-on skill stations. So you see on the right, you have the EMS providers are working at stabilizing a child who suffered a trauma. They're putting a C-collar on, getting the patient on the backboard. And then we did want to spend a small amount of time in lectures, didactic lectures. So we wanted to make sure that we weren't spending too much time just talking to the audience. We wanted to be more interactive. But we also recognize that given that many of these nurses and medical technicians working with the EMS team, they did not have prior pre-hospital background, we did feel that it was important to have a small component, or at least a component of didactic lectures, just to give the team some background. So once we decided on simulation as the main modality, we chose the specific types of sim training that we would do based on the available resources. While there are many different types of simulation available, our focus was on a more low fidelity simulation, again, based on resources available, and knowing that we wanted to develop a program that would be sustainable. So as I mentioned before, through a grant that was provided by Texas Children's, we were able to procure pediatric, infant, and adult mannequins, and also different skills training equipment for this EMS training program. There was a lot of ancillary equipment like bag valve mask and like normal saline bags and IV starter kits. Much of this, the ancillary equipment, was collected via donations or expired equipment from Texas Children's Hospital. And we would just be specifically using this for the training and not for patient care. So there are a few different ways in which to conduct simulation training. Here are three of the more common types of simulation training that you can use. The first type, feedback and debriefing, is more traditional, where you start a scenario and just let a team go all the way through the entire scenario. And then at the end, you provide the team with evaluation. I think one of the downsides of this, or one of the challenges with this type of training, especially with our inexperienced group, is that if they go down the wrong trail or misinterpret a scenario, they spend a significant amount of time doing different tasks and skills that may not be needed for that specific scenario, which led us to really think that the best way to develop or to conduct our training program was really to do a rapid cycle deliberate practice type approach. And this approach for simulation, it allows for more purposeful and systematic repeating of the scenario. So you stop simulation sessions when you feel that the team is either maybe getting off track, or if there are important points that you want to emphasize. And when you stop, you provide those teaching points. You can either start from the beginning, depending on how far you are into the scenario, or you just continue, just start up where you stopped and have them continue through the scenario. So it does interrupt the flow, but as I mentioned, it does provide an opportunity for teaching learning points at that point in time. It also gives the team an opportunity to repeat and practice the different skills that you're teaching. There's also another level, which is mastery learning, where you're building on key critical points and you add on complexity as you go. And this certainly is something that we're looking at developing as this training program has developed, but certainly not, we weren't looking to start off with mastery learning. So regarding the implementation of the program, the following, the following are steps that I feel are crucial. We talked about identifying key stakeholders. As part of that, you want to make sure that you have the support that you need for the curriculum. This is not something that you do once you're ready to start the curriculum. As I mentioned before, you need to spend time before even developing the curriculum to get this support, so that you know that the key stakeholders are invested and that you've already developed relationships with the people that you're working with, and that you fully understand the different systems and processes. You do want to identify all the resources that are available and procure any resources that might be needed for the curriculum. For example, for us, we needed to procure the simulation equipment. You want to identify and address any barriers to implementation of the project. For example, as I said, if there's no defibrillator available, it wouldn't make sense to train them on how to defibrillate. And then you want to make sure that you pilot the curriculum, spend time and just doing small group training sessions, because sometimes you feel like you've created the best curriculum, but when it turns out you actually try to pilot it, maybe you're missing your mark. So important to pilot it and then adjust the curriculum as needed. And also, as I'll mention in just a little bit, the importance of doing to train the trainers. So you want to make sure that the team that you're training has ownership of this program. And so it was very important that our team from Texas Children's was not the one standing up and doing all of the training, but instead it was EMS providers from the Ministry of Health that we trained. They were the ones who were going to be the instructors. And then you do want to make sure that you administer this to your target audience and then refine over successive cycles. You're going to get feedback, and if you feel like you. So, as I mentioned, we started off the trainings throughout the country. Our goal was to really do trainings in the 3 largest EMS centers in Botswana. Really the first thing that we did, as I mentioned, was to do the train the trainers. And this was a specific course focused on teaching the trainers the basics of simulation education methodology, teaching them specifically how to deliver feedback, and also focusing on the education material content, making sure they had a good handle of that so they can answer any questions that might be asked. By doing this, the goal was that we would help promote sustainability for the program. They would not be reliant on the Texas Children's team in the future to conduct these. So as I said, we started off doing the trainings in 3 different centers. We decided the trainings would be executed over a 2-day period with a mixture, as I said, of lectures, sim scenarios, skill stations, and then we would have pre and post testing sessions to help us in evaluating the effectiveness of the program. And then all participants, including the trainers, receive certificates from the Ministry of Health upon finishing the program. So as you develop your curriculum, it's really essential to think about the evaluation process early on. You want to think about how you're going to measure your success. And so one model that we use and that you're seeing here on the screen is basically Kirkpatrick's level of evaluation. I'm sure many of you have already heard about this, but this describes basically 4 levels to evaluate or ways to evaluate a training program. And then, the first level, which is the most basic, is the reaction of the participants of the training. And so this is via self-assessment. So a lot of times you just have them fill out questionnaires. You're trying to figure out if the trainees got what they wanted out of the course, and do they feel more comfortable with the skills that they were taught, et cetera. The next level is the learning. This is assessed via doing pre and post tests. So we administered both written pre and post tests, and we also did simulation scenario pre and post tests to see as ways to measure their learning. Behavior change. This is asking or assessing whether or not they've been able to apply what they've learned. This is typically is very difficult to measure, but one of the goals when you are developing a curriculum is trying to figure this out. We did this, and I'll go into this in a little bit, but we did this by assessing the EMS patient report form. So every time EMS goes on a response call, they fill out these patient report forms. And so we analyzed these report forms pre and post training to see if the team is actually utilizing the skills that were taught. And again, we'll give more about this in a little bit. And then the top level of assessment, and by far the most challenging, is results. And so was there an actual change? And so in this type of training, the big question for us is, did we have an effect on morbidity and or mortality? There are many challenges in getting to this level. I think for us, one of the biggest challenges that we've faced to date is that all the charts are paper-based. And so really trying to look at, not only would we be looking at just the pre-hospital data, but we would be linking the pre-hospital charts to the emergency department charts and trying to do this over a long period of time or a longitudinal way is incredibly difficult, as these charts go missing, they go into huge storage spaces, and really trying to sort through them is incredibly difficult. So I think this is something that we're aspiring for, but again, very challenging to reach that final level. So here's a look at some of our results. I'll go through these relatively quickly, but when looking at that first level at provider confidence, pre and post training, for the pediatric training, we noted an overall improvement of 15.5% of the actions that were listed and taught during our training. For the pediatric content, when comparing pre and post test scenarios, we found an average change of 21%. And for the written test, we saw an average improvement of 10%. For the adult content, as I mentioned, or I think you've picked up on, we developed kind of two different simulation training programs. The pediatric program, which I'm focusing on now, but we also developed an adult component. And so for the adult content, when comparing pre and post simulation scenario tests, we found an average change of 33%. And for the written tests, we saw an average improvement of 18%. So as I mentioned before, in evaluating how can we evaluate the curriculum for practice change, we decided to do a review of those EMS patient report forms pre and post training. So basically we did a power calculation for sample size, and then reviewed patient report forms that were completed by the Botswana Ministry of Health EMS providers who participated in the training. And the goal was really to evaluate specific tasks completed by the providers as recorded on the patient report forms, which are filled out on every patient response call. And for this data collection, I did some of the data collection, but also we trained Ministry of Health EMS staff to assist in the data collection. The exclusion criteria, the calls that we excluded were any transfer calls, those calls where you were just transferring a patient from one hospital to another. Excuse me, we did not include patients that were either not transported, so EMS responded and they decided not to transport, or patients that were found deceased. We did not include any pre-hospital providers who did not complete the training. At the time of the review of these patient report forms, there were many new EMS providers that had joined the staff, and so we did not include them unless they had, as I said, completed the training. So we reviewed 348 patient report forms from 6 months prior to that first training, and then 350 patient report forms from 6 months post-training. And again, only those, looking at only those who completed the training. Looking at the patient report forms and matching it up with what we taught, we found that there were 21 separate actions that could be evaluated. And again, these are all actions that were taught in the training and could also be recorded on the patient report forms. So we did find an improvement in 9 of the 21 actions that were taught, a significant improvement in just taking vital signs. And that's really this first part on the left. We did see an improvement in documenting past medical history, We also did see improvement in a lot of the procedures that we taught, such as C-spine immobilization, utilizing backboard, extremity splinting, and administering IV fluids. There were a number of these categories where we either saw absolutely no change at all, and most of the time they had not done the procedure or task before, and then they did not do it after. For example, examples of that would be defibrillation, some oxygen intervention, like applying nasal cannula, and really the main limitation in doing that is they just didn't have the equipment available, the oxygen tanks. But we did see some improvement in the tasks that were taught and performed. The limitations of evaluating the behavioral change, we did, on any one response call, there are multiple team members that are on a response call, and it's possible that the EMS provider who was trained was not necessarily the one documenting. It was, we had the names of the EMS providers on the patient report form, but couldn't distinguish exactly who was actually writing. And then we had another challenge in that in 2016, so right in the middle of us evaluating this, the Botswana Ministry of Health decided to adopt a new patient report form. So a different format. It had a lot of the same information, but it was just portrayed a little bit different. And so to correct for this, we just compared the patient report form pre-2016 and the one used after July 2016, and we only collected data that was present on both report forms. Again, an inherent challenge, as I mentioned before, a lot of these, all of these report forms are paper-based. So we're going through paper-based charts, and there were some patient report forms that were just missing. So in conclusion, simulation training, we found and literature supports this, really helps to increase provider confidence in the management of, for our program, in the management of different pediatric and adult presentations in the pre-hospital setting. It did improve provider knowledge base, and we feel it may have influenced an improvement in pre-hospital provider care. It was associated with enhanced compliance with the documentation of pre-hospital actions, but we certainly recognize that there are many opportunities for us to improve. I think we can certainly focus on the areas of weakness identified in the training, and really investigate why some procedures are not being performed. And really, this is an opportunity to help prioritize the procurement of equipment via the Ministry of Health for basic EMS procedures. And then there are opportunities to expand the curriculum. To date, during COVID, there was definitely a decrease in the number of trainings, but since the training started, there have been more than 20 trainings throughout the country in 10 different Ministry of Health EMS stations. And again, these are led by the Ministry of Health EMS providers. As far as our lesson learned, developing an education curriculum, it takes time. So this project, really 2013, 2014 was the first time I was on the ground. The curriculum really didn't get up and running till about 2016. So it just takes time. So just make sure you don't take shortcuts, just recognize that it takes time to develop these programs. Can't stress enough the importance of defining the needs of the learners. By far, simulation is an excellent hands-on approach to teaching. We had great success with this program. Teaching, again, it's important to do the train the trainers. It has to be conducted primarily by local champions. And there's a need for evaluation of any curriculum you develop to make sure you're meeting your goals and objectives. Make sure that when you're developing these programs that you do develop or utilize technology that's appropriate for the setting. And then also, creating a dynamic interactive process helps keep the attention of the providers, makes it more fun, and provides for a great way for them to learn. I would promote that or suggest for any of you that are looking to develop a curriculum, make sure, I do feel that it's incredibly important to share the curriculum that you have developed and disseminate the information that you've learned from this. These are just a number of the, I think 1, 2, 3, 4, 5 different manuscripts that we have published as a team. So a mix of the Botswana Ministry of Health and Texas Children / UCSF team that has worked on this project. And we have a couple more pending manuscripts regarding this project. So can't emphasize this enough to make sure that you are providing open access to these manuscripts and disseminating what you've learned. As far as our next steps, we continue to expand and add additional simulation scenarios for the team to practice and to learn from. I'm constantly looking for different funding for further, especially for further additional simulation equipment. We know that the simulation equipment that we've been using has had a lot of wear and tear over the years, as you can imagine. We can, as I said, create new scenarios and get new task trainers. Those are all going to be priorities. We are looking at developing a community-based EMS program. So Botswana is unique in that it's a relatively small population. There are about just over 2 million in the whole country, but there are a large percent of the population that live outside of main urban centers. And so we've talked about possibly developing a community-based EMS program to help supplement the Ministry of Health program. So that is coming down the road. We have some residents from Texas Children's who hopefully are going to be doing an initial needs assessment within the next year, pending the availability or opportunity to travel given the pandemic. So with that, we'll open up for any questions. And these are just some photos of some of the trainees and some of our Texas Children's team that participate in the study. So thank you.
Thank you, Nick. That's amazing work, what you've done. I will open up to anyone who wants to come off mute and ask a question or put something in the chat. And then also as a plug, we have an evaluation. If you could please fill it out, I'll put it in the chat, the link.
Hi, Nick. This is Liz Sanso. Great talk.
Hey, thanks.
I'm going to keep the video on mute because I have a baby on board. Oop.
No problem.
My question, I love the train the trainer and that this program has been sustained through, the newly trained trainers doing the curriculum, and that's incredible. How do you know, my question is, how do you observe, know that the trainers are doing the training the way that you kind of designed it for them as it goes on? And are the trainers, the newly trained trainers, training other trainers? Yeah. Or is your team going down and training new trainers? And how is the curriculum adapted based on feedback from the trainers, like the pre-brief aspects, like the pre-brief, setting the psychological safety, maybe the debrief? Have you guys incorporated any feedback based on local customs, say, as that curriculum changed based on their feedback?
Yeah, great question. So the first question, how do we know the trainers are hitting the marks and doing a great job with the trainings? For a couple years after we started the training, I continued to work to help to facilitate these training sessions. Myself and at least one other faculty from Texas Children's would go over and we would mainly just be there as a resource for the trainers, and would let them do 100% of the training. And so this really gave us an opportunity to give feedback to the trainers as they continue to teach this curriculum. And so it was, I found that was incredibly helpful and important to have that. And so just like in developing any curriculum, or like training a resident, you don't want to just like set them free and then expect that, or have no opportunity for feedback. And so we found that it was incredibly important to have additional staff on the ground to provide them with long-term feedback. As far as the training, other trainers, so our goal is to have at least a couple trainers at each of the EMS sites. And so it was becoming a bit expensive. Ministry of Health would cover the travel costs for the trainers to go to the different training sites for the first couple years. But it was definitely becoming a little bit expensive when you consider housing, transportation, to do that long term. And so our goal was to, recognizing that our goal was to train at least a couple EMS providers at each site. That has been done, I would say, at least at 10 of the EMS sites. So there are definitely opportunities to continue to do that. This is right now, the EMS sites are popping up all over the country. Every year they're adding 3-4 new sites. And so we'll just have to continue to make sure that there are trainers at each of the sites, because it's just not practical to have one group of trainers rotate around the country every year. And another challenge is in doing that and having them travel was moving the equipment around. There's a lot of wear and tear to the simulation equipment. And so we've really become a little bit creative in the sim mannequins that we use. Sometimes there are mannequins that are available through borrowing it from one of the local hospitals. Sometimes we just make mannequins ourselves. So it's obviously not with all the bells and whistles, but again, we developed this training program on a very basic simulation level. So I wanted to make sure it could be replicated. As far as feedback, we do have annual feedback from the trainers. We have the participants that go through the training, provide us with feedback, and we have multiple different scenarios that are, they've asked for, additional training in disaster management, because trauma is incredibly common throughout the world. But there's one main highway that runs north-south through Botswana, and there are unfortunately many large-scale MCI type events where a bus crashes and you have multiple victims that the EMS team has to triage. And so that feedback has really helped us in identifying opportunities for additional curriculum material.
Thanks, Nick.
Absolutely.
Nick, we have several trainees actually on watching the lecture today. And I was wondering what advice you have for people who are interested in global health education and curriculum development. Like, where do you start? Do you start with formal training? Do you start by getting involved in a project? What's your advice?
Yeah, I think it's a little bit different now with the pandemic, but I think, from my experience, I think one of the best things that you can do is, spending time on the ground in whichever country you decide to work with. Spending time and really understanding, try and let go of any preconceived notions and make sure you take the time to understand what the different problems are. And I think kind of look long-term at how you might be able to contribute, and just be realistic about your timing. And it might be difficult during residency. You might have only 1 or 2 months to actually work abroad. But I would spend that time developing the relationships and looking at ways in which you can, help out long term, and as a faculty, hopefully continue to develop a curriculum, start a project, etc. I do think, there are many, especially at UCSF, there are many different faculty that are involved in global health projects, whether it's research or this is educational research, or, curriculum development. I think trying to get involved with faculty that already have an ongoing program during residency is incredibly helpful. But I think, certainly that when possible, when, hopefully the pandemic calms down, that on the ground experience, I think is incredibly useful, and will serve you well, spending that time in the beginning, in the long run.
Thanks. Completely agree. I think that longitudinal relationship is so key for making the lasting difference. So thanks for pointing that out again.
Absolutely.
Any other questions, either in the chat or anyone want to come off mute?
Yeah, I had a question. Hi, my name is Meadow, and I'm one of the second-year pediatric residents. I was wondering, in that patient report form, is there a way to add like outcome where it's like patient was stabilized or needed escalated care, just so that maybe you can start getting like the outcomes and providing those results to like the trainees as incentive or something? I don't know if that's something is possible.
Yeah, that's a great point, and great question. I think the ideal way that we would do that is link the EMS care with the ED care. And so showing that, patient is, let's say they have an asthmatic and a nebulizer treatment's administered, and they arrive to the emergency department, and, patient stabilized and is able to be discharged home, looking at kind of the morbidity of the patient. That would be the ideal way. I think it's a little difficult because the pre-hospital time frame is such a short period of time. It's hard to it's a great point, and maybe we could assess the improvement in the patient status during the transfer, whether it be pain control, the respiratory distress after a certain intervention. So I think there certainly are opportunities for that, and something that we could look into. So that's a great point, and a way that we could possibly look at it without needing to link to the ED data.
And then thank you. And then one other question I was wondering is there a way to apply this or in more rural settings? I know like cities have more resources, but I don't know if that's something like that you've thought about I know it's like access is going to be an issue, resources are going to be an issue, but how something like that could be developed.
Yeah, and there are models for community-based EMS programs that have been developed. And it's, no bells and whistles. It's, taxi drivers, or you train taxi drivers, or you train local stakeholders within a community to serve as a kind of a emergency medical service transport. And sometimes you're just transporting, in a private car or on a donkey cart, whatever the setting is. But certainly there are models of different community-based EMS programs that could help to supplement or complement the EMS programs that are based out of the main cities. And so I think that's one of our next steps, kind of something that we're looking at developing now in Botswana, just because there are just so many opportunities to improve the care of the patients outside of those urban centers. So absolutely, and that's a great point.
Thank you.
Thank you.
Well, Nick, I'd like to thank you so much for your time and for this awesome lecture. Really learned a lot from this work that you've done. And I wanted to remind everyone again that the link is in the chat. If you could please fill out the survey. It's very brief. It's literally 2 questions and will take a minute of your time, but the information you provide is very valuable. So thank you so much, Nick. Really appreciate it.
Great. Thank you, everyone. Appreciate it. Thanks for your attention and great questions.
Thank
Have a
you.
great day.
Bye now.
Bye.